Hello everyone, and welcome to today's webinar titled Refocus Your Enrollment to the Subpopulation of Interest with ENRICH. I would now like to introduce Pantelis Vlahos, Principal Strategic Consultant at Cytel.
Thank you, Lisa, and once again, thank you everybody for attending this last session on our East Orientation webinar series. Just to recap, to see where we were and where we've come, we started with some early phase webinars on the early phase arena. So we looked at dose escalation methods. We looked at phase 2 dose finding with the use of the MCP module. We looked at phase 2-3 designs with the MAMS module, and we also looked at adaptive confirmatory designs with SURVAdapt. So today we're going to go back a step. The module that we're going to be revisiting today is going to be, can be thought as sort of like falling into the phase 2-3 arena with adaptive population enrichment. And I'm going to waste no further time in getting into it. So the format is going to be identical to what we have done before. We are going to be visiting initially the methodology that the module is based on. We're going to be seeing the application of that methodology through a case study. And in the end, we're going to allow for some questions and, of course, the conclusion of it. Once again, this is the collection of modules that are available in EAST. We have seen quite a few of them right now, but our emphasis today is going to be on the ENRICH module, which allows for population enrichment in studies with survival types of endpoints. So this is the flashcard for the module, but I think the best thing to do is to see a small graphic that gives us the idea about the module itself. So this is something that works quite a bit like a standard group sequential design, where we would have an interim analysis, and at that interim analysis, if we have convincing evidence of efficacy or futility, we would stop the study. Otherwise, we would continue, and there are a couple of ways that we can continue. We can continue with the original sample size in place for the full population of interest, if the results at the interim fall in what we call the favorable or the unfavorable zone, or we can continue with an increased sample size. And that can be also thought about being partitioned in two pieces. We can either continue with an increased version of the original population, the full population, or we can think about enriching a particular subpopulation, so continuing only with an increased sample size on a part of the population. And the way that this enrichment is going to be done is going to be dictated by the next few slides I'm going to be mentioning. So here we are in the area of population enrichment, where we want to prospectively use any patient characteristic to obtain a study population in which it's going to be easier to detect an effect than in the entire population. So basically, our patient population can be partitioned into two subpopulations, and the types of partitioning can be done either in terms of prognostic biomarkers. These are prognostic factors. These are when we have different biomarkers that helps us identify high-risk subjects, or whenever we have a case where a certain number or a certain kind of patients is more likely to respond to a particular treatment, which is the case of predictive population enrichment. And this is pretty much what we're going to be dealing with today. The use of population enrichment becomes more and more appealing with the cost of trials increasing, and of course with the discovery of blockbuster drugs on decline, where we're moving now away from the one-size-fits-all idea. So our goal here is to help identify a highly responsive group and detect the treatment effect with a smaller sample size. And this becomes more appealing because you might have failed molecules from one study that may succeed on a different group. And there are several examples of this that have been shown in the literature in the past. The example of Opdivo and Keytruda is one of them, as well as the study, the famous I-SPY 2 study, where different combination therapies were identified across different biomarker subgroups. So as I mentioned, our method today is going to be based on predictive enrichment. The population is going to be divided in two groups based on this anticipated response to the treatment, and the study would materialize in two independent cohorts. So we're going to have the first cohort, which is going to be recruited from the full population. Then we're going to have the interim analysis, and then the second cohort, each recruitment will depend on the results of the interim analysis based on the data that we have from the first cohort alone. And then at that interim, you may either continue with the full population, with the subpopulation, or you might stop the study. The graphic that is typically being used in this, which enables us also to see that indeed we have a two-stage design, is the following. So you have the all-comers. You have all-comers coming into two treatments of interest. We have the interim analysis, and then at the interim analysis, we might have the different decisions at our disposal. We can imagine that we have a p-value which is based on data just from cohort 1. So this part only alone, and then a p-value based on data from cohort 2. The use of these two p-values will also help us preserve the type 1 error. And the methodology that we're going to employ for that is the methodology of closed testing, the principle of closed testing, in which if we have individual null hypotheses for the full and for the subpopulation respectively, and we also denote by H0 of Fs the hypothesis, the global null hypothesis, closed principle testing will state that if we're interested in declaring the full population as significant, then we need to reject the hypothesis both on the full population as well as any intersections in which this population appears, which in this case is just H0 of Fs. Same thing with the subpopulation. It can be deemed significant if both tests for the null hypothesis that involves the subpopulation as well as the intersection are significant at the local alpha level test. Now, the way that we guarantee that type 1 error is being preserved with closed testing is by combining the p-values. This is an approach that we also saw on the MAMS module with the p-value combination approach. In the case of no enrichment, we have these conditions to fall in order to declare significance in the full population, while in the case of no enrichment, of enrichment, we declare significance in the subgroup if the bottom bubble holds. So here, basically, by P1 of F and P1 of S, we denote the marginal one-sided p-values for the full population and the subpopulation, which are based on data observed only from cohort 1. And then P1 of Fs denote the adjusted p-value for cohort 1 for the global null. There are different ways of obtaining this adjusted p-value. Similarly, P2 of F and P2 of S denote the marginal one-sided p-values for the full population derived from cohort 2 alone, if it is decided not to enrich, and P2 of S is the corresponding one for the subpopulation derived from cohort 2 without enrichment. And just as before, when we talk about P2 of S, we're talking about the adjusted p-value for cohort 2 in the case that there is no enrichment, because this is something only used in the case of no enrichment in the top bubble. So this is the backbone of the methodology that we're going to be using, and we're going to see this in the case for a case study taken from the area of angiosarcoma, which is an ultra-orphan disease. And in this disease, we have a monotherapy which has been used, which is pazopanib, which is a VEGF inhibitor which shows modest benefit. And then we have the treatment of interest, which is TRC-105, which can be used in combination with pazopanib to see whether or not we can demonstrate superiority of that combination versus the monotherapy. Now, this case naturally lends itself to adaptive population enrichment. First of all, because of the small population, we are talking about 1,800 cases at most per year. But in a phase 1-2 study, which was done on soft tissue sarcoma patients, this combination of TRC105 and pazopanib demonstrated durable complete responses and a median PFS of 7.8 months in angiosarcoma subjects. So the benefits actually in the subjects with cutaneous lesions appear to be superior to that of patients with non-cutaneous disease. So we have an indication about sort of like the possible subgroup that we would be interested in, which is the one where subjects have the cutaneous lesions. So this is our trial objective. We want to demonstrate the superior progression-free survival in the combination versus the monotherapy. And what we need to note here, however, because we are talking about a time-to-event endpoint, is that there are several peculiarities about this study. First of all, there are the standard time-to-event issues where the PFS events and not the sample size is going to be the primary driver of the power. The sample size does play the role as we need, and as we saw in SURVAdapt, as the larger the sample size is, the sooner the events will arrive. But there exists this trade-off between the number of events, the study duration, and the sample size. This exists for all time-to-event studies. It's not something that is specific to this particular study. What is specific to this particular study, however, is that some subjects who are administratively censored in the dataset available for the interim analysis might subsequently experience an event. So if one were to make available data in the patient profiles for these subjects in the form of toxicities, lab values, the extent of tumor shrinkage, then this might be correlated with the PFS to assist in the enrichment decision. And that may lead to an inflation on the type 1 error. So this use of auxiliary data breaks essentially the independence that we need to have between the p-values from the two stages. But thankfully, Jenkins, Stone, and Jennison in their 2011 paper suggested an alternative and a solution to this. Whereas the study population is now split in two subsequent cohorts whose initial sample sizes and PFS events are pre-specified prior to unblinding the data. So we're going to be trying on different combinations of number of events and initial sample sizes for each one of the cohorts. Cohort 1 is going to be enrolled, followed by cohort 2, and at the interim, which occurs while cohort 1 is still accruing the pre-specified number of events, of subjects and PFS events, the data are going to be unblinded to an IDMC, which is going to be recommended one of the 4 zone decisions. This recommendation will only apply to the subjects of cohort 2. And the type of decisions that were available, we already saw them on the graphic that I showed you earlier in the slides. So in our case, let's see in EAST what is expected out of this, how we can actually deal with the situation. So what I'm going to be doing is initially, I want to get an idea about the number of events that are required in the case where the hazard ratio is about 0.55. It's expected to be in the area of 0.55. So in the control arm in pazopanib, we have a median time to progression of 4 months, leading to 7.3 months essentially for the combination for a hazard ratio of 0.55. And you can see here, if we assume an accruals of about 8 subjects per month, that for 83% power, we would require 96 events. And we would require 124 subjects to be recruited in order to get us these events within 15.5 months. So this is sort of like the standard time to event, 6 design, which we saw earlier on also last week when we talked about the sample size re-estimation process. So this is going to guide us initially to give us an idea of how many events we're going to be needing, in this case 96, and how many total subjects we would need to recruit, in this case 124. Okay, so then we might try and see what we can do with the enrichment process. So just to show you how this looks like, the menu, we would have to go under the survival part of the ribbon and select the log-rank test given accrual duration and accrual rates under the population enrichment, which would bring us up with several tabs. This is, again, a simulation-based procedure, like most of the adaptive procedures in EAST are. In the first tab, we would have to set the design parameters. In the second tab, we would have to set the adaptation parameters, how we're going to be proceeding with the increase of events and sample size in the full population, as well as in the enrichment in the subpopulation, depending on values of the conditional power in the full population and in the subpopulation. And finally, the standard simulation controls tab, which is there for all of the simulation-based procedures. So let's see sort of like the specific inputs that we would have for our particular trial. So we have 96 events and 124 subjects. And naive, a very first preliminary approach would be to say, well, what I'm going to be doing in the design parameters tab, I'm going to be splitting this number of subjects and these number of events equally into the 2 cohorts. So cohort 1 is going to have 62 out of the 124 subjects and 48 out of the 96 events. Same thing with cohort 2. And at the interim would be based on 40 events. So we could pre-specify this breakdown of number of events and sample size at the interim. Then we would have to also specify what sort of reality scenario we're generating. So there are different ones that we can generate. So you can generate one where for the subpopulation of interest, in this case, the cutaneous group, we have a hazard ratio of 0.55. And for the complement of that, the visceral group, we also have 0.55. But we can also generate different other scenario where it might seem that there is a benefit to the cutaneous group. So we might have 0.55 on the hazard ratio for the cutaneous group versus 0.7 or 0.85 or even 1 for the complement of that. For this particular case, let's start initially by considering no difference between the 2 populations in terms of the reality that we're generating. So overall, in the full population, we're going to have a hazard ratio of 0.55. We're using the same assumptions in terms of recruiting subjects, 8 subjects coming in per month. But initially, I'm going to not perform any adaptation at all. So I'm going to set my maximum sample size at 124. So I'm not going to be increasing that. I'm going to set my maximum number of events at 96, as they were originally, and which means that pretty much these areas here, which we saw also on the SURVAdapt, will be ignored. So the promising zone, which is from 0.3 to 0.9, the target CP for re-estimating the number of events, that also is going to be ignored. And then if we are not going to be performing any enrichment as well, the original number of subjects that we anticipated to have from the enrichment group, because we had a prevalence of about 50% from that group, is about 62. With half of those approximately the events, half of the 96 events coming from that population as well. But here we're going to be enforcing not an enrichment, because we are pretty much saying that we're going to be enriching only if the conditional power under the full population is below 0.3 and the conditional power under the subpopulation is greater than 1.1. So this obviously cannot happen. So basically we're saying that you're not going to be enriching. And we're also not going to be stopping for futility, because we would terminate for futility if the conditional power under the full population is less than 0.3 and under the subpopulation is strictly less than 0. So none of these things, well, the second part cannot happen. So basically, we will be running a simulation for the non-adaptive case, just to get an idea of what sort of output we're going to be obtaining from this. So no sample size increase in the full population, disabling enrichment in the subpopulation. One of the plots that is very helpful here is this sample size and events over time plot, which I'm going to be maximizing here, just to examine it in a little bit more detail for this particular breakdown that we have done between number of events and sample size. So you can see here, if I move the vertical cursor left to the right, and I reach, for example, the point where my interim analysis is supposed to take place, 40 events, which is about close to 12 months. So I would see that by that point, all my sample size for the cohort 1 has already been attained, because the sample size for cohort 1, which is this red line, actually gets attained at this point, which is at around 7.8 months, right? So at 7.8 months, if you look at the value in the top right of my screen, that's the point when I have already reached my cohort 1 sample size, which means that from that point and onwards, up until the point of the interim, I will be recruiting additional subjects, but these subjects, until we get to the interim point, will come from both populations, both from the cutaneous as well as the visceral population. So if I were at this point here, at the point of the interim, to decide that there is going to be enrichment, so I need to focus from that point onward only on subjects in cohort 2 that come from the subpopulation, then you can see that at that point, which is at 12.3 months, I will have recruited 98 subjects from cohort 1 and cohort 2 alone. So, and that is an addition of 36 subjects from cohort 1. And I'm anticipating, with a prevalence of 0.5, that half of those approximately should be from the visceral group. Half of those should be from the cutaneous group. So if my decision at the interim is to enrich, that means that practically I would have to throw away data from half of these 36 subjects. Okay, so that is quite a bit of data to ignore, especially in a case where we have a rare disease. So that actually tells us here that we should probably think about the different breakdown in terms of the number of events and the sample size. And that's what I'm going to be looking at in the next step. However, if I were to just look at the details of this simulation where I have not performed any adaptation, you would see that out of the 10,000 simulations, I would end up rejecting the null hypothesis about 74% of the time. So that would be my power for this compared to the 83% of the fixed design. But remember, we have not done any adaptation here, and the loss is just due to the use of the close testing. So an adaptive population enrichment should only be considered if there is a possibility that there is a strong treatment effect in the subpopulation, but not its complement, right? So this is what we're going to be examining now in the next scenario that we run. So in this particular scenario here, which I can edit so that you can view its details, we have now looked at a different breakdown between the number of events and the sample size. And this is actually the breakdown which is mentioned in the slide that we have. So 70 subjects from cohort 1, 60 events. Again, the interim look takes place after 40 events, and we have 54 and 36 subjects in the cohort 2. And I have run different types of simulations. This particular simulation is when there seems to be a treatment effect on the subcutaneous group. We have a hazard ratio of 0.55 versus a hazard ratio of 0.85 in its complement. And therefore, we're going to be performing an adaptation where the sample size in the full population would be increased up to 200 and the number of events up to 170. While if we are in the enrichment zone, the sample size is going to be increased up to 135, with the maximum number of events increased up to 110. So you can see that the promising zone is if our conditional power in the full population is between 30 and 95%. If the conditional power for the subpopulation is greater than 50%, then we have reason to enrich. And if the conditional power is actually in the subpopulation is below 0.1, then we would be stopping the study for futility. You can also see here that with this breakdown, we are doing much better in terms of the data that is left unused. So the point at which we have exhausted the sample size from cohort 1 is this one, which is about 8.8 months. So at this point, the cohort 1 sample size of 70 has been exhausted, and at the interim look takes place after a total sample size of 86. So roughly an additional 16 number of subjects have been enrolled up until that point, which means that if we did decide to enrich, then we would probably have to ignore about half of those, so about 8 subjects compared to the 19 subjects that we had to ignore in the previous case. Of course, you can always readjust and play around with different breakdowns of your situation to try and optimize the study from that end. But also you have to keep in mind that you have to also optimize it in terms of the power in the promising zone and the power in the enrichment zone. So if I were now to run the simulation under this scenario and I look at the results of the simulation, we would see that now my unconditional power has fell to about 62%. But when I fall into the promising zone, which happens about 37% of the time, which you can see it here, my power gets back up to about 81+%. In the enrichment zone, which also happens about 19% of the time, my power goes up roughly to about 76%. So, and we also have obviously what the power in the favorable zone is going to be. So this, in addition to other scenarios, have been run as well. So scenario where the hazard ratio for the subpopulation is 0.55 versus 1 for its complement, 0.55 versus 0.55, and 0.55 versus 70. And the results of these simulations have been summarized in the table that you see here on the slide, which allows you to see the advantages of the enrichment and how the power in the zone of interest, which is the promising zone, goes consistently to be above 80%, except maybe for only one case here. And of course, it comes at the expense of the additional sample size, which is only going to be called upon if this is needed, much like what we saw on the use of SURVAdapt. So this is our procedure. This is how we run adaptive population enrichment in EAST. And I would like to thank you. And I would like to thank you all together for attending, especially for those of you who have attended all 5 sessions up until this point, and give you now a chance to submit your questions on our chat. And while we gather those questions, I will also let Alyssa go through a couple of slides and a couple of messages from Cytel.
Thank you, Pantelis. Before we move into the Q&A, we want to take a moment to remind you that EAST gives you easy access to a wide selection of trusted fixed and adaptive trial designs. EAST is used by nearly every major pharmaceutical company and the FDA. With a broad selection of popular designs in easy-to-use formats, we can help you quickly create and compare trial designs. Our company also offers a range of services from staff that act as an extension of your team and consulting services for more cutting-edge projects to our new real-world analytics capabilities. We are here to help support your objectives.
So while we're also waiting for to collect the questions, let me recap that with the conclusions of today's webinar, compared to a fixed design of about 200 subjects, the adaptive design provides greater power, smaller sample size, and shorter duration. It maintains 18% power in the favorable, promising, and enrichment zones for a hazard ratio of 0.55 in the cutaneous group, even with larger hazard ratios in the non-cutaneous subgroup. With this, we are recapping our webinar series, which has been, as I mentioned earlier, consisting of themes across all different stages of development. And I would like to welcome you to respond to the survey in the post-webinar thank you email that you will be receiving. And if you need a certificate, to please request that as a response to that email as well. So I guess we can go into any questions that might be collected up to this point.
Great, thank you, Pantelis. We have a few questions here. Our first one, do we find the biomarker in interim analysis, or is the biomarker already identified outside of the study in an earlier phase or in a preclinical trial?
In our case, we dealt with predictive population enrichment, which means that the subgroups that we had the separation that we had in our population into the different subgroups were defined by different anticipated responses to the treatment of interest. So it wasn't, we did not base this on biomarkers. If we had to base it on biomarkers, then these biomarkers would have to be already predefined and validated. So we would need, for this procedure, we need to have the subgroups to be already predefined, well-defined in advance, so that we know on our adaptive procedure which subgroup to look for in when we are performing the adaptation. These adaptations have to be pre-specified, as you know, and as we discussed also on the SURVAdapt webinar.
Thank you. And our next question, how are subjects assigned to cohort 1 or cohort 2? Is this based on randomization?
Yes, so it is based on randomization, right? So you could also have subjects being stratified, but it is, yeah, it is just a regular 2-arm study, right? But you could stratify them also by their subpopulation membership.
And our next question, how is type 1 error maintained?
So type 1 error is maintained through the concept of close testing, because the challenges that we have here are sort of like threefold. We have multiplicity, which is related to testing two hypotheses. We have a hypothesis for the full and for the subpopulation. Then we also have a challenge for the possibility of increasing the sample size and the number of events based on the IDMC blinded decision, which could inflate our type 1 error, and that's why we're using the promising zone methodology. And of course, we also have the issue that I mentioned on this slide here on auxiliary data, where some subjects whose time to progression is censored at the time of the interim might have the event by the time of the final analysis. So all these are challenges that are brought forward in this particular study, and we are addressing them through the use of combination of close testing with the combination function approach. And actually what we are using here, I don't think I mentioned that. So in this example, for our example, we used for the global null, we use the sign-adjusted p-value both for cohort 1 as well as for cohort 2.
Thank you. And we have a follow-up question to the question on assigning how subjects are assigned to cohort 1 and cohort 2. So are there 2 layers of randomization? One is to assign subjects to cohort 1 and cohort 2, and then within each cohort, there's randomization of the treatment and the control?
Okay, so in cohort 1, you are assigning all comers, right? So all comers, which means that subjects from both subpopulations are being assigned there, and you can have a stratified randomization into treatment and the control. Then at the interim analysis, you will have to make a decision on whether or not you're going to be continuing with the full population, in which case you continue the randomization the way it was done at the first stage, or whether or not you're going to be continuing with the subpopulation, right? So if you are continuing in the subpopulation, again, you're going to be randomizing just that subpopulation into the 2 treatments of interest.
Thank you. And we have one last question here. And as a reminder, feel free to type in your questions and I will read them out to Pantelis. So our last question here is, what sort of endpoints can you use the ENRICH module in EAST for?
Currently, as I think I showed on the EAST menu, this method is available for time to event endpoints. This is one of the examples where a particular method resulted from a consulting assignment that we had within the company, and this has been the way of graduating methodologies within EAST from different consulting assumptions. The other way that we do it is, of course, by receiving the feedback from our users, seeing what are the methods that they're interested in and try to add them into the software. So in this case, this resulted in the case from a case in oncology or in angiosarcoma in a particular study where we added this functionality. But of course, we can also, we are working on adding this for different types of endpoints as well. For the moment, in version 6.5, only time to event endpoints are entertained.
Thank you, Pantelis. And we have one more question that just came through here. Are there situations where the sample size will need to be increased after interim analysis? How is type 1 error controlled and maintained below 5%?
Yes, so there are a couple of situations where it will be increased, and maybe that initial schematic will help us get to that. So if your results fall into the promising zone, then you will increase the sample size in the full population. If the results fall in the enrichment zone, you would increase the sample size for the subpopulation of interest alone. And the type 1 error, as I mentioned in I think it was the first question, we are maintaining it in a couple of ways, so that we are performing close testing for the p-values onto the 2 groups, and for the decision on whether or not we increase in the promising zone or the enrichment zone, we are using the promising zone design with the Kuihung and Wang statistic. Once again, so if there are questions, obviously, please let us know about them. Otherwise, don't hesitate to contact me directly or contact our team. And if you have any support issues from the usage of EAST, you can also address them to support@cytel.com. But for any other specific issues that you might have with any of the methods that we covered up until today, feel free to drop me a line and I'll be more than happy to respond at the earliest point.
Thank you, Pantelis. And thank you to everyone for attending today's webinar. And on behalf of Cytel, thank you for joining us today and have a great rest of your day.
Thank you, everybody.